Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host Nykki, who handles the headlines. Take it away, Nykki.
Thanks, Tony. We've got some genuinely interesting research to dig into today. None of it headline grabbing yet, but all of it the kind of thing that tends to matter quietly in the background while you're dealing with everything else menopause throws at you. Let's start with fibroids. A paper published August 12th by Michael Monroe in what looks like a gynecology review context is making the case for what the authors call precision care in leiomyoma management. Leiomyomas, fibroids, are benign uterine tumours that affect somewhere between 70 and 80% of women by the time they hit 50. That number alone is worth sitting with for a second. This is not a rare condition. This is an extremely common condition that gets treated as though every case is interchangeable. The argument Monroe is making, and it's a reasonable one, is that fibroid care needs to account for phenotype, meaning what the fibroids look like, where they are, how many, how large, alongside actual symptoms, where a woman is in her reproductive life and what her treatment goals are. Because a 38-year-old who still wants to get pregnant, a 46-year-old in perimenopause with heavy bleeding, and a 52-year-old who's postmenopausal and largely asymptomatic should not be getting the same conversation. Obviously, and yet that's often what happens. The perimenopause piece matters, especially here. Fibroids are estrogen sensitive, and in the perimenopausal transition, when estrogen levels are fluctuating wildly before they eventually drop, you can get a window of worsening symptoms, heavy periods, pelvic pressure, the whole picture. And then postmenopause, when estrogen drops, fibroids typically shrink. So the timing of diagnosis and where a woman is in her hormonal arc really does change the calculus on treatment decisions. My read on this paper, the precision medicine framing is aspirational. The research community has been talking about individualized fibroid care for years, and the gap between what the literature recommends and what actually happens in a 15-minute OB/GYN appointment is real and documented. But I'm glad the argument is being made again, clearly with reproductive goals specifically named as part of the decision framework. Too many women in perimenopause have been pushed toward hysterectomy without a thorough conversation about where they are in the transition, whether symptoms might resolve on their own timeline, and what they actually want. The paper doesn't fix that gap, but it's doing useful work naming it. The second study is one I want to spend a little more time on because the finding is more specific than the headline suggests. Published August 5th, this is a study by Avgusti and colleagues looking at hepatic steatosis, fatty liver disease in postmenopausal women. Now, fatty liver is one of those conditions that's accumulated a lot of clinical attention over the last decade because it's on the rise globally and because its connection to metabolic syndrome is well established. What this study is trying to do is figure out, within postmenopausal women specifically, what predicts severity. The finding they're highlighting, it's not just adiposity, body fat on its own that drives how severe the liver involvement is. It's the accumulation of multiple cardiometabolic risk factors together. We're talking about the cluster: central obesity, insulin resistance, dyslipidemia, that's abnormal cholesterol and triglyceride levels, elevated blood pressure. When those stack, the hepatic steatosis tends to be more severe. Not surprising mechanistically, but it matters for how we think about screening. Here's what I think is clinically relevant. Postmenopausal women who have one or two of these risk factors often don't get a liver conversation at all. Fatty liver doesn't cause symptoms in its early stages. You won't necessarily feel it, And unless someone is ordering an abdominal ultrasound for another reason, it tends to go undetected. The cardiovascular risk factors will often get tracked, but the liver often won't. This study is making the case, implicitly, that women who have multiple cardiometabolic risk factors after menopause should probably be having a proactive conversation about liver health, not waiting for an incidental finding. I want to be accurate about what the study can and can't tell us. This is a cross-sectional design, which means it's a snapshot. It's not following women over time, so it can't tell us that having these risk factors caused worse liver disease. It's showing an association at a single point in time. That's a real limitation. But the association is consistent with everything we know about metabolic disease progression and the practical implication that cumulative risk should prompt liver screening seems sound. Estrogen's role in liver metabolism is also worth flagging. Estrogen has a protective effect on lipid metabolism and insulin sensitivity, so its decline at menopause is part of why postmenopausal women become more metabolically vulnerable. This isn't the first study to look at that relationship, but it adds to the evidence base that menopause is a metabolic inflection point, not just a reproductive one. The bone study is the third piece, and I'll be honest that the primary focus of this paper, Akkad and colleagues, published July 31st, is kidney transplant recipients, not menopausal women generally. It's a cross-sectional study looking at bone turnover markers, DXA results, and mineral metabolism in people who've had long-term kidney transplants, comparing them to a control group. The reason it's relevant here is what it reveals about the gap between what a DXA scan tells you and what's actually happening in bone. DXA, dual energy X-ray absorptiometry, is the standard bone density scan. Most women in or after menopause who get any bone screening will get a DXA. It measures bone mineral density, gives you a T-score, tells you whether you're in normal range, osteopenic or osteoporotic. That's all useful, but density is a static measure. It tells you how much mineral is in the bone at that moment. It doesn't tell you how fast bone is being lost or rebuilt, what's called bone turnover rate. Bone turnover markers, things like serum CTX for resorption and P1MP for formation, are blood and urine tests that give you a more dynamic picture. They can detect accelerated bone loss before density has dropped enough to show up on a DXA. In the transplant population, this study examined, there were mismatches, cases where the DXA looked relatively stable, but the turnover markers were telling a different story. Now, kidney transplant recipients are not representative of the general postmenopausal population. They have specific immunosuppressive medication effects and mineral metabolism issues that most women won't share. So I'm not reading this as a direct clinical recommendation for menopausal women. But the underlying point that DXA alone has a limited view of bone health is relevant. We know that the perimenopausal and early postmenopausal period involves rapid bone turnover. The bone isn't just getting less dense, it's actively remodeling at an accelerated rate driven by estrogen loss. Turnover markers can capture that dynamism. They're used more routinely in some countries than others, and in the US, they're not a standard part of most postmenopausal bone health workups. If you've had a DXA and your doctor said you looked fine, that's genuinely good news. But if you have other risk factors, family history, low body weight, smoking history, or you're early in the transition and losing bone fast, it might be worth asking whether your bone health picture is complete. A DXA is one data point, not the full story. Tags: fibroids, leiomyoma, perimenopause, fatty liver disease, hepatic steatosis, cardiometabolic risk, bone density, DXA, bone turnover markers, postmenopause, metabolic health, women's health research.
Thanks for listening to Hot Flasher. We're back tomorrow with more, so don't forget to subscribe. See you tomorrow.